Good morning from Ottawa. So this is my place that I get to treat patients with my colleagues who are part of our research teams. I have nothing to declare. I am involved in two research studies, one funded by IBM and Simvar, and the other is an in-house funded project, which is the one I'm going to talk about. So at the end of this presentation, if you get nothing else out of it, if all I do is foster an interest in virtual reality for the treatment of complex pain conditions, then it's mission accomplished. So how is virtual reality used for pain diagnoses? VR can be used as distraction, embodiment plus augmentative activity, addressing balance and vestibular faults such as vestibular ocular reflex dysfunctions, saccades, or proprioception dysfunctions, used for motivation and enjoyment or for relaxation. And what does the literature tell us about these? So the theory around using VR for distraction is if we're attending to a sensory stimulus, we will perceive a nociceptive stimulus as less. And we know with distraction, the PAG, the perigonal ACC, and the orbitofrontal cortex activity increases, and the thalamus insular cortex and the mid-cingulated ACC activity decreases. And VR gives us many options to vary sensory stimuli to create those distractions. And if we look at what has been found thus far for using distraction as a principle in VR, it's been used for dental procedures, venous access procedures, burns, oncology, and dressing changes successfully. So, sorry, I just need to move something here. If we use it for embodiment, and we do a fair amount of this for our CRPS patients, and we've been working with VR clinically for over 10 years in our Karen lab. What it allows us to do is create a malleable illusionary ownership of a virtual body. And we know from research that humans can embody very different avatar bodies, and anybody who plays video games has experienced this. Cortical changes in certain chronic pain conditions manifest in altered body precepts, creating an opportunity to manipulate this body image. And if we think of CRPS or phantom limb pain, where we know that those body image precepts have changed. So using VR, we can enhance various multisensory inputs, and we can do that with visual and proprioceptive feedback, or visuomotor feedback, or visual tactile, depending on what VR instrument you're using. So you also can think of using embodiment of really getting at what we know about pain, and that's that predictive processing perspective. So vision is weighted higher than other sensations, and multiple concurrent sensory inputs strengthen that embodiment illusion. Visuomotor congruence is stronger than visual tactile. And we can also use movement of the contralateral limb to move the ipsilateral avatar limb. And that sort of gets to almost a mirror therapy process of using embodiment in VR. And various researchers have looked at using embodiment for SCI, neuropathic pain, applying those asynchronous and synchronous visuotactile stimulation. And they found that this decreased pain and improved embodiment. There's very low quality evidence that embodiment as a way of avatars exercising improved symptoms of persistent chronic pain and changed rumination, magnification, and helplessness in the PSA. We can use a mirror system Mirage box to decrease pain by changing the size and shape of fingers in patients with rheumatological conditions. And in chronic arm pain, which involves some CRPS patients and some patients that did not have CRPS, altering the limb size and augmenting it with vibrotactile stimuli with a head-mounted display improves signs and symptoms. So we can also take embodiment and use augmented activity. I have to admit this is beyond anything we're doing in our lab, but there are people out there doing it, particularly with phantom limb pain. And what they found by using augmented activity, you could decrease the pain improve ADLs, and improve sleep. And they went beyond the use of visual sensory cues by using the phantom sensation feeling that patients with phantom limb pain have to execute a motor response of the phantom limb in the avatar while that avatar was walking. And they used a myoelectric pattern recognition software to do this. And this is a really good example how expanding our teams beyond traditional healthcare workers to rehab engineers or software engineers could really help us use VR to optimize pain relief in patients with complex pain conditions. We also can use it by addressing balance, and we frequently don't think of balance problems with pain conditions, but many of our patients with pain conditions, for instance, chronic migraine, post-concussion, CRPS patients are falling all the time. We can take these high-tech simulated real-world conditions and challenge balance systems at higher levels. And we know from a review of the literature done by Santos that a VR-based postural controls assessment gets at things that we're not capturing with low-tech exceptions. And it may identify when persistent perceptual motion disintegration is occurring despite clinical postural control tests showing that the person has recovered, particularly with incongruent visual inputs. And we also can use VR by using it for relaxation, and optimizing relaxation really promotes downregulation of pain by using visual biofeedback in which the environment responds to the user's physiological behavior during the exercises. So Darnell et al. Used a combination of CBT, self-management principles, biofeedback, and mindfulness. And as you can see, they got a pretty good success overall with, most importantly, the global impression of change from respect of the patient group. It's also been used for using deep breathing and downregulation techniques to decrease headache, nausea, and dizziness. And we have used it with patients with autonomic symptoms, sympathetic symptoms, using graded exposure and using relaxation downregulation techniques while we're using these greater exposure approaches. And we really target what the sensory input is that's driving those autonomic symptoms. And just general evidence of the use of VR in chronic pain has shown that immersive systems are better, and projection systems like IREX or 𝐒𝐔𝐁𝐄 don't get as good a result. And there is very good evidence for the use of VR in acute pain, particularly burns. So this is our care-in system, and this is the group of people I get to work with for my little project. Courtney Bridgewater is a rehab engineer, and Emily Siniski is another rehab engineer that's helping out. And the process that we like to think when we approach using VR with any of our patients, be it clinically or be it in research, is we're really thinking about that the VR environment can allow us to isolate different input sensory signals. And we're testing the black box of the brain to see what the outputs are and where the deficits may be. So all neural signals have inherent noise, and perception is an action potential frequency modulated outcome. Just because one patient is going to respond one way, or that same patient is going to respond this day, does not mean the response is going to be the same the next day or the same in another patient, even with the same diagnosis. So considering all our sensory inputs as well as memories, and thinking about all our responses to them, including emotional responses, autonomic responses, cognitive responses, really gets us the ability to tailor the VR program to help that individual patient. So our purpose for our pilot project of 5 cases, and yes, it is just 5 cases, but the CRPS population is hard to get enough patients, but not just enough, those that are suitable to put into a research program. So our exclusions were severe depression and severe anxiety, and only severe because most patients with CRPS tend to exhibit signs of depression and anxiety. We've also excluded the other DSM diagnoses, such as bipolar. And we see actually a fair amount of CRPS patients with other diagnoses. So it has been a task to get enough patients to enter into this pilot, as well as we started it just before before COVID, which was a bit of a disaster. So the outcome measures that we are using are the compact measures developed by the ISP CRPS Special Interest Group for CRPS, the PROMIS measures for sleep, as well as sleep logs, the Bath Body Perception Scale. We're using a simulator sickness questionnaire to help making sure we're not over-treating patients and causing undue autonomic type symptoms after the fact, and Karen precision measurement systems. So the Karen assessment that we do involves using Vicon markers to tell us where that patient is in space, as well as their movement and their coordination. We're measuring angles of visual neglect. We're looking at head positioning during the visual angle testing, and we're using movement data during the center of mass shifting trials to evaluate timed task completion, movement efficiency in different movement areas. So the picture at the right doesn't show a full avatar, but if you notice the two tiny white dots, when we build a full avatar to take these measurements with the Vicon markers, what you'll see is a stick man moving in space on this screen, which tells us weight bearing and exactly where they are in space, as well as where their pressure points are. So one of the measures that we're taking during the Karen assessment is the center of pressure velocity measures. And it is an approximation of the velocity of a subject's center of mass projected onto a 2D plane under the subject's base of support. We use 4 measures calculated and compared to a group of healthy control subjects, and we have a database of healthy controls for these measures. The mean of the absolute value of the center of pressure velocity time series, the standard deviation of the center of pressure velocity time series, the minimum value of the center of pressure velocity time series, and the maximum of the COP velocity time series. The minimum and maximum velocity values were calculated as a sign of the min and max, and suggest that there is a directional component to the peak velocity measures in CRPS patients. Mean COP velocity is also calculated, and it is a basic measurement of postural stability, whereby a larger mean velocity value signifies greater instability. And I realize this is very dry, but this is where the bulk of our data is actually coming from. And the standard deviation of the center of pressure velocity time series is a measure of postural stability, where it is not just a larger velocity of the center of pressure, but a greater possible range of velocity. And greater excursions or larger peaks in center pressure velocity suggest less postural stability. The standard deviation of the center of pressure velocity time series is also a measure of postural stability, where it is a measure of not just the larger velocity of center of pressure, but a greater possibility of range of velocity, meaning greater excursion or larger peaks in center of pressure velocity, which suggests less postural stability. I think. And the min and max center of pressure velocity provides a peak of the center of pressure velocity, but with the added information of direction of the peak speed of center of pressure, which actually is important, that directional piece. And in the case of the coordinate systems of the lab, the positive direction of the x-axis is towards the subject's left, and the positive direction of the y-axis is towards the posterior of the subject. We also look at the area of the 95% confident ellipse, and it gives us an approximation of the area within which the center of pressure wanders. And some random movements of the center of pressure position is expected and is normal, but large excursions, especially uncontrolled excursions, can suggest that the position of the center of pressure, and therefore the center of mass, is not well controlled. And when the position of the center of pressure is not well controlled, this suggests that the postural balance is impaired. So that was a lot of complicated sort of, maybe not for all of you, but sort of measurements. And we do 24 treatments in our VR lab, as well as standard evidence-based treatments for CRPS, which include sensory integration, graded exposure, as well as graded activity and graded motor imagery. This is with permission, one of our patients using the bridge application, where we can change wave height, wave direction. We can change how much this bridge sways up, down. We can make this stormy. We can add lightning to increase vigilance. It allows us a lot of possibilities. So where are we now with our study? We actually have data for 2. I lost the data for our 3rd subject due to COVID and our subsequent shutdowns. And so by the time we got that patient back in, there really was no point continuing the study. Subject 4 has just started her trial and is 1/3 of the way through. We paused it for a long while because for 24 treatments in succession, with the hospital opening and closing to outpatients on a regular basis in Ontario over the last 2 years, it really was difficult to run a research trial within those parameters. So what have we seen thus far? Our subject 1, when we started the study, did not have impaired body image disturbances, so we really weren't expecting a change. Subject 2 had fairly significant ones, and we've seen large improvements in her body perception precept for her leg. And subject 3 was demonstrating improvements in overall her body image precepts at the time that we had to close down our study for COVID. Using the compact measures, we haven't really found any significant change other than the pain catastrophizing scale has improved. And sleep measures, which the title was lost in that box, sorry about that. Subject 1 was unimpaired, so we weren't expecting a change. Subject 2 improved in time and quality, and subject 3 at the time of her last treatment improved in time and quality as well. Thank you. So what did we find? If we look at the Karen assessment, we found that the minimum and maximum velocity values as calculated indicate that there is a directional component to the peak velocity measures. And the standard deviation showed greater excursion or larger peaks in center of pressure velocity, which suggests that these patients have less postural stability and that we were able to impact this. So the interpretation of the min and max COP velocity results showed that CRPS subject 2 had significantly higher COP velocity in all measures, left, right foot, combined COP in the XY direction for maximal and minimal velocity. Initially, she used the handrails extensively in the initial assessment eyes closed trials, which was really suggesting impairments in postural control because she could not stay upright without them. With her eyes closed. And once visual information was removed, not even the addition of supplemental proprioceptive information from the handrail was enough to maintain equilibrium. Use of the vestibular and proprioceptive information for postural control appeared to be insufficient, and the subject relied on visual information to maintain upright stance. Her post-training results showed improvement to the initial assessment. When she completed the eyes closed trial, she used minimal use of the handrail compared to initial, and a slightly greater impairment is seen in the AP direction, especially posterior maximal center of pressure Y velocity, where the p-value of the t-test difference between the subject and the healthy control is more significant. Subject 3 demonstrates a significant difference between their minimum COPD values in the x-axis for the left foot, combined to the center of pressure compared to healthy controls in eyes open. This showed her subject's postural control in the right direction is impaired, especially control or rightward movement in the left leg. Given that the difference was seen during eyes open but not eyes closed condition, it would suggest that the subject misuses visual information for postural control, even when the visual information is minimal, and that should say, and stable. As symptom provocation had increased after eyes closed condition, it could also suggest that the extra cognitive resources were used to maintain posture when visuals removed, creating better postural control, but with the price of increasing symptoms. And that's just suggesting, we're not saying for sure, obviously, from a pilot. And large uncontrolled excursion can suggest that the position of COP and therefore COM is not well controlled. When the position of COP is not well controlled, this suggests that the postural balance is impaired, and subject 2 had very large excursions that improved after treatment. And that is our complicated data that we have gathered thus far. I wish that we actually had the full trial, but unfortunately COVID has messed with our data collection. And that is all I have to present for today.
Thank you so much, Janet. That was amazing. It's so fascinating in looking at how technology can become part of the solution, because I know over COVID, there's been lots of complaints about technology being part of the problem. So we had a lot of activity around questions. And one of them was, how do you factor in their learning style when you're introducing them into virtual reality? And then also, how do they then translate that into real world environments?
That's actually a really good question. So I don't really see VR as the only treatment. So factoring into real world environments, whatever we do in the VR lab, we are trying to mimic walking on uneven surfaces. We're trying to mimic lots of visual motion and incongruent current visual inputs, such as being on a busy street with a bus moving in the wrong direction. But obviously we can't just do that. As a clinician, I wouldn't leave it at that. I definitely would make sure that they can operate in a real world environment. And the first part of that question was?
Their learning style.
Their learning style. So yes, didactic learners don't do as well as in this environment because trying to explain completely what we're trying to do is difficult. Experiential learners do quite well, and they may be the group that respond best to virtual reality. However, we haven't incorporated that into our pilot, but when we go to do the RCT, maybe that would actually be a really good question to ask as part of the RCT. So thank you for raising it.
And the other piece that someone was asking about is those who may be less successful using virtual reality. Are there certain factors, because we can learn from that as well? What are certain factors that you find are more challenging for individuals trying to use virtual reality?
The things we've learned so far is people with severe motion sickness are not going to do well in this environment. Working with combat soldiers, we've discovered that there are certain applications you have to be careful of. We learned from our soldiers returning from Afghanistan, certain images in our apps of huts reminded them of Taliban huts or irrigation channels where bad things had happened. Certain noises sound like bullets, which we're not using a combat zone. Certain noises are triggering. So it really is important. And in a presentation I did for CPA, I talked about you need to get to know your patient before you use VR, because you need to understand more than just what we typically do. You need to understand where they're coming from. Have they been in a combat zone? Are they a refugee who's seen war? What things have happened to them? So you can think about what is a safe thing to do to start your patient off in treatment. And you may, with a psychologist, move towards there. And I have done that with some of my combat soldiers in conjunction with a psychologist for patients with PTSD and pain. But as a physio, that's out of my scope to do it alone.
Absolutely. And I think that's a really great way for us to finish, again, tying in that piece that we need to get to know our patients. So thank you so much. By all means, stick around for the rest of today, and we're going to be moving on.